Thank you, Joan. We're Joan L and Joan M, so we're good. So we're going to talk about wellness in graduate medical education. This is very important. I have no financial disclosures because I haven't figured out how to make money from wellness. If I do, it'll be good. As many of you have probably seen, 54% of doctors say they're burned out. 88% of doctors are moderately to severely stressed, and 59% of doctors wouldn't recommend a career in medicine to their children. Those are really alarming statistics in terms of the health and welfare of our profession. We also know that burnout is nearly twice as prevalent among U.S. physicians than among workers in other fields. The ACGME instituted these clinical learning environment reviews a few years ago. Raise your hand if you know what that means when I say that. So some. It's sort of akin to a joint commission visit where they're coming to look and see the learning environment in which the residents are training. And they use audience response, so the residents, when they meet with groups of residents, they can provide their honest feedback. But one of those questions that they ask about is what the trainees observe among their faculty. And 88.8%, multiple institutions across the U.S., those trainees observed signs of burnout among their faculty members and program directors. So I found that very concerning as well. A few years ago in the Washington Post, there was a lead story, nearly a third of new doctors at high risk for depression. And this addressed residents in training. And the overall finding was that about 29% of physicians in training had depression or depressive symptoms, and that those symptoms increased over time as residents progressed during their training program. So as we said, there's high prevalence among practicing physicians, but also among medical students and residents. And the work hour changes do not seem to have improved the reports of burnout, sleep deprivation, depression, errors. And this resident distress can be associated with increase in medical errors and poorer patient care. Medical trainees experience higher rates of depression and burnout than their age-similar individuals pursuing other careers. So there's a nice article published about changing the conversation from burnout to wellness, physician well-being and residency training programs, and certainly focusing on the causes for burnout are important, but how do we really implement and support wellness in our training programs? The ACGME has also made this a priority with a new section in the Common Program Requirements on well-being, and this was instituted in 2017 with sort of a gradation in terms of when they will start citing programs and institutions. But they say residents and faculty members are at increased risk for burnout and depression. Psychological, emotional, and physical well-being are critical in the development of the competent, caring, and resilient physician. Self-care is an important component of professionalism. It's also a skill that must be learned and nurtured in the context of other aspects of residency training. And the sponsoring institutions are just as responsible for ensuring that the residents are trained in a culture of wellness as the programs are. And in fact, we should consider this just as important as other aspects of residency competency. So some of the priorities were that we should protect time with patients. As you heard, the residents are spending more time with the computers than they are with the patients, that we should try to minimize some of the administrative functions that they've traditionally done that really don't help in their overall education. We should address scheduling issues, and not just in work hours, but work intensity, work compression, the stress that residents are feeling from that. We should make sure that our trainees have opportunities to attend to their own health care and wellness. They should be able to get to their medical appointments and dental appointments. If they're working 80 hours trying to fit their own appointments in are really not feasible, so they should actually be allowed work time to do that. And we need to have policies and procedures. And specifically, those should support residents being able to fulfill this wellness without fear of negative consequences. So we don't want them labeled as a wimp because they say that they need this time. There was a publication this year in New England Journal, "To Care is Human, Collectively Confronting the Clinical Burnout Crisis." And the authors make the points that clinicians are humans, and delivering the best care takes a personal toll on them. We hope, if they really are humans. But the burnout is really putting patient safety at risk. because it can be associated with increased rates of medical errors, increased malpractice suits, and healthcare-associated infections. And they concluded we have an urgent shared professional responsibility to respond and to develop solutions. 400 physicians commit suicide each year, which is more than twice that of the general population. And you see that nurses also experience emotional exhaustion at very high rates. And the National Academy of Medicine has actually produced or developed a website where these materials are available. This particular physician said, "I consider myself one of the lucky few who made it through with relatively few scars, but so many healthcare practitioners silently bear the burden of not only struggling to care for their patients, but also for themselves." So there was a call to action, and multiple organizations are involved in this. The National Academy of Medicine is involved, but also the AAMC and the ACGME. And the action steps suggested in this call to action are that we need to increase the visibility of clinician stress and burnout. We need to improve healthcare organizations' baseline understanding of the challenges to clinician well-being, to identify evidence-based solutions, as you heard from Kim, and to monitor the effectiveness of implementation of these solutions. So as I said, they did develop this website with resources that are available. One of the things that they mentioned, though, was certainly there are external factors. It's not all related to the work environment, but there are personal factors involved, such as inefficiencies, the cumbersome IT systems that we've all experienced, the workloads, the work-home conflicts. We talked about the second career, particularly when women go home. Problems with organizational culture, team dysfunction that might interfere with their workload, perceived loss of control and meaning at work. But they said, although personal factors unrelated to the clinical environment, such as being young, female, or a parent of young children or teenagers, might also contribute to greater risk of burnout. But we're not going to really address this right now. We need to sort of look at the bigger picture. So, you know, when I read this, I thought, we really have gender discrimination. And it's like, yeah, it might be worse for you, but never mind. You know, we'll get to you eventually. So that did concern me. And I think we really need to advocate for the special needs of women, and I'll talk a little bit more about that in the next session. So this is my ad to please stay with us for the next breakout session to come. Thank you.